In this final section about the hand, we will go over some common hand pathologies seen on X-ray. Starting distally and working our way more proximally, we will start by talking about tuft fractures. These are quite common and result from trauma to the distal finger, the tuft, usually due to a crushing mechanism like hitting it with a hammer. As a result, these fractures are often open, which would be seen on physical exam. Here is an example of an X-ray showing a non-displaced longitudinal D4 tuft fracture. And then this photo shows an example of what it would look like to have an open tuft fracture on physical exam. Next, mallet finger is another distal finger injury that occurs when an object hits the fingertip, usually kind of straight on like that, and it causes the extensor tendon to rupture on the dorsal aspect of the finger, and it results in the deformity seen in the photograph. The hallmark of this injury is the inability to extend the DIP joint, and mallet finger is an injury that can sometimes, but not always, be seen on X-ray. It is a clinical diagnosis. So while an extensor tendon rupture can occur without causing any bony injury, so as you can see here, the extensor tendon can be ruptured without affecting the bone, you may also get an avulsion fracture of the distal phalanx, so P3, and that can be a clue on X-ray that you do have a mallet finger. Thus, if you see a dorsal avulsion fracture of the distal phalanx on X-ray, it is usually a mallet injury. So you can see here there's a chip of bone and avulsion fracture that indicates a mallet injury, but this needs to be correlated clinically. However, if there's no avulsion fracture on X-ray, it can still be a mallet diagnosed clinically if the patient is unable to extend the DIP joint. Dislocations of the MCP, PIP, and DIP joints are also identifiable on X-ray. Dislocations can be dorsal, volar, or lateral, but dorsal is most common for all three joints. The dislocation is described based on the position of the distal bone compared to the proximal bone. For example, the first image here shows a dorsal PIP dislocation with shortening because the more distal segment is dorsal, and there is overlap between the two bone segments, showing shortening. Here is another example of a D5 PIP joint dislocation, which is a lateral dislocation because it goes sideways. Besides an obvious misalignment at the joint, signs of dislocation on X-ray can also include joint space widening. So you can see this joint here is a little bit wider than the others. And that can indicate that the volar plate, which is a ligament on the volar side or the palmar side of the finger that supports the PIP joint, is stuck inside the joint, or you may even see a sesamoid bone stuck inside the joint space. So an example of that is seen here. You can see there's a small round opacity in the joint space of the D2 MCP joint, and that is a sesamoid bone that's stuck in that space. Remember that getting multiple views is very helpful in the diagnosis of dislocations and should be done routinely with a hand series. Fractures and dislocations may also occur together, aptly named fracture dislocations. These often involve the PIP joints when there is both a dislocation and a fracture on the same bone, usually the middle phalanx. As you can see here, there's a fracture and a dislocation at the middle phalanx of the PIP joint. There are three accepted categories of fracture dislocations: dorsal, volar, and pilon. And pilon is when the dorsal and volar sides are involved. The fracture dislocation is named based on the dislocation. This can get confusing because while it makes sense based on the direction of the dislocation, it is usually the opposite side that has the fracture. So for example, here in type 1, you have a dorsal dislocation. Let's say this is the dorsal edge, so you can see the middle phalanx is going upwards. However, the fracture is actually on the volar side of the middle phalanx, the volar lip. Opposite to that is type 2, so it's a volar dislocation. The middle phalanx is displaced volarly, however, the fracture is on the dorsal lip. And then finally, you have the pilon PIP fracture dislocation, where you have both the dorsal and the volar lip are fractured, and the dislocation can be in any direction. Next, a boxer's fracture is named after the common mechanism of injury, punching something at a high enough speed or with enough impact to cause a fracture in the fifth metacarpal, so the small finger metacarpal bone. It is classified as a break of the fifth metacarpal neck, as seen on the X-ray here. This is a commonly seen fracture in the emergency room, and usually angulation of this type of fracture is dorsal, which causes a characteristic bump with swelling and pain on the dorsal ulnar edge of the hand, as shown here. This is a good example of when measuring angulation on the X-ray is important. The fracture angle is best measured on the lateral or oblique views. And so, as we already explored in the last video, we looked at the angulation table with this image, and we saw that it was less than 50 to 70 degrees, and so it will likely heal in an acceptable position for function and does not need further reduction. The next type of common fracture is called a Bennett fracture. This is a fracture of the thumb metacarpal at its base that is intra-articular, making it an unstable fracture. As you can see here, it extends into the joint space. It's a partial articular fracture, meaning that the fracture involves part of the articular joint surface, but not the entire joint. Several tendons, in particular the abductor pollicis longus, or APL, attaches at the base of the thumb, and this exerts a pull on the fracture segment, which tends to cause dislocation of the joint. This fracture was named by an Irish surgeon, Dr. Bennett, because he cautioned that even though these fractures may look relatively simple on X-ray, with just kind of a single line extending, and you can see here in the X-ray, a single fracture line extending into the joint here and then once again there, they are actually very unstable due to their joint involvement. Because of the instability, these fractures often require surgery, and so you don't want to miss these on X-ray. There's also such a thing as a reverse Bennett's fracture, named because it is very similar to a Bennett fracture, but instead of the thumb, it is the small finger. Thus, it is an intra-articular base fracture of the fifth metacarpal bone. Both Bennett and reverse Bennett have tendons attaching at the site of fracture and exerting force that can displace the fracture piece and make them more unstable than they may seem at first. So like we talked about with the Bennett fracture, having the APL, the abductor pollicis longus, pulling on the fracture segment. For the reverse Bennett, you have one of the extensor tendons, the extensor carpi ulnaris, or ECU, that exerts force on the fracture segment and can cause displacement and dislocation of the joint because it does extend into the joint space there. And this makes it a very unstable fracture and often will require surgical management. So here is a radiograph showing that. So you can see that it's very similar to the Bennett fracture. This is just a base fracture of the fifth metacarpal that extends into the joint there. And even though it may not look like much, the fact that it's extending into the joint and has the force of the ECU, the extensor carpi ulnaris, on that fracture segment can make it quite unstable. Rolando fractures are also very similar to Bennett fractures. The Rolando fracture is seen here, right there, is basically a more extensive Bennett fracture. They both occur at the thumb metacarpal base, and they both involve the articular surface, so they go into the joint. While a Bennett fracture is a partial articular fracture and is usually just a single fracture line that extends into the joint space, as you can see here, the Rolando fracture involves the entire joint surface, so it's a complete intra-articular fracture versus Bennett, which is just partial. A Rolando fracture, because it involves the entire joint surface, is either comminuted, so it has a shattered appearance at the joint, or it has this characteristic Y shape, as you can see on the diagram here. These fractures are even more unstable than Bennett fractures because of their greater joint involvement, so identifying them on X-ray is important to guide treatment. Next, skier's thumb is another injury that is sometimes, but not always, seen on X-ray. This injury occurs when the thumb is forced radially, so outwards, which causes stretching or tear of the thumb's ulnar collateral ligament on the inside or ulnar edge of the thumb. It is called skier's thumb because the mechanism of this type of injury typically occurs during a fall and sometimes when the hand is outstretched, such as when holding a ski pole, as shown in the image here. The ulnar collateral ligament is on the inside, and so it gets stretched when the thumb is forced radially. Gamekeeper's thumb is another term for the same injury of the thumb's ulnar collateral ligament. However, the difference between skier's thumb and gamekeeper's thumb is that gamekeeper's is a chronic injury from repetitive stress over time, whereas skier's thumb tends to be a single traumatic event that tears the ulnar collateral ligament of the thumb. While you can't see a ligamentous injury on x-ray, and a normal x-ray doesn't rule out Skier's thumb, quite often an x-ray can show you an avulsion fracture, which indicates that there is likely a Skier's thumb, similar to what we saw with the mallet finger avulsion. The avulsion, if it is present, occurs on the ulnar side of the proximal phalanx base of the thumb, where the ulnar collateral ligament insertion is. So here you can see a few good examples of avulsion fractures right where you would expect the insertion of that ligament. However, this would have to be clinically correlated as well. Occasionally, you may also see bony tumors on hand x-rays. These can be benign, primary malignant, or metastatic, though malignant bony hand tumors are extremely uncommon. Enchondromas are the most common bony tumors seen on x-ray, and these are benign tumors originating from cartilage. You can see an example of an enchondroma on x-ray here in the D5 metacarpal. It is a well-circumscribed hypodense area within the bone. The initial presentation of an enchondroma is somewhat nonspecific often, with pain, swelling, and deformity, and often presents as a pathologic fracture due to weakening of the bone from the tumor. So here you can see an example of a pathologic fracture on the 5th metacarpal because the enchondroma creates a especially vulnerable weak spot in the bone. Usually enchondromas present as well-defined solitary lesions in young people, so like we saw in the last 2 x-rays. If multiple enchondromas are identified on a hand x-ray, this is called enchondromatosis and is associated with syndromes such as Ollier and Maffucci and should be worked up further. An x-ray showing extensive enchondromatosis associated with Ollier syndrome is shown here, and you can see that there are quite a few enchondromas visualized. While this course focuses on hand x-rays in an acute setting, it is also worth mentioning chronic changes that may be seen on x-rays so that we don't confuse them with acute pathology. Osteoarthritis is a very common degenerative condition with increasing prevalence with age. It is characterized by joint pain and stiffness, and commonly it affects the PIP joints, the DIP joints, so PIP joints, DIP joints, and the thumb base, also known as the carpometacarpal joint. Some key findings of osteoarthritis on x-ray include the following. So you may have joint space narrowing. So here's an example of a normal joint. You can see the joint space in between the middle phalanx and the distal phalanx. Here, in the osteoarthritis example, the cartilage within the joint is lost and the articulating surfaces become a lot closer together. You may also have subchondral sclerosis, so that's seen here as these hyperdense whiter areas just adjacent to the joint. You might also have subchondral cysts, which are hypodense cystic areas adjacent to the joint, and osteophytes, which are extra bony outgrowths adjacent to the joint. In cases of thumb base or first CMC arthritis, you may also see some compensatory changes. So you may get this hyperextension of the first MCP joint, and you may also get slight squaring at the thumb base, as seen here. Finally, in addition to osteoarthritis, inflammatory arthritis, such as rheumatoid arthritis, may also present with radiographic changes. Early RA typically doesn't show changes visible on x-ray, but over time it can lead to radiographic signs. Commonly, the affected joints exclude the DIP joints, so do not include the more distal joints. They tend to be symmetrical and also often involve the wrist joints. So this is a diagram of typical joint involvement for RA and the typical radiograph that you would see in more advanced stage rheumatoid arthritis. So going a little bit more into the signs of rheumatoid arthritis on x-rays here, usually with rheumatoid arthritis, you will have erosions and inflammation of soft tissues and joints. So erosion is the loss of bone due to the inflammatory processes of RA. And that's in contrast to sclerosis, subchondral sclerosis, which is a thickening of the bone seen in osteoarthritis. So one way to differentiate the two types would be rheumatoid arthritis has erosion, loss of bone. Osteoarthritis has sclerosis, thickening of bone. Advanced RA can also show significant deformities clinically that can sometimes be seen on x-ray as well. And this would include the zigzag sign. And so you can see in this radiograph here that the fingers deviate ulnarly while the rest of the hand deviates slightly radially, creating this zigzag appearance, and that's one indicator of rheumatoid arthritis in its more advanced stages. So this concludes the hand module. While it is not an exhaustive list, we have just reviewed a number of common hand pathologies that may be seen on X-ray. These conditions are commonly encountered in the emergency room and in clinic settings and are important to recognize. In the next section, we will move on to the wrist.